she told me like to always remember that patient is somebody's brother, somebody's mother, somebody's grandma, and my family is of paramount importance to my life. And so I've taken that very, very seriously. Like, there is a balance in there that can be had, but maybe that's sometimes difficult. But remembering that that's somebody's family, it was the best advice that I think that my folks gave to me.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Hey everybody, and welcome back to the Art of Emergency Nursing. This is Kevin McFarland, your host, and I want to thank you for being here on the podcast with me today. If you haven't already, please make sure that you've subscribed to the podcast to make sure you don't miss an episode. And I really need your ratings and reviews. Your rating and review helps other people find this podcast, helps like-minded people find the podcast, so hopefully they can enjoy it too. Now, the best thing you can do for the podcast is make sure that you recommend it to a friend. If you have a friend who listens to podcasts and you think they might be interested, give us a shout out, let them know on social media, let them know in person. I always appreciate that. I just got back from San Diego for the ENA State and Chapter Leaders Orientation, and holy cow, I got a ton of great feedback. Got to see a lot of old friends and got to make a lot of new ones. So that was a lot of fun. Shout out to Justin. Justin's a listener of the podcast. Just finished his NCLEX. You may have seen me on Instagram posting that, good luck. But sure enough, he did it. He is now a nurse, just now getting his RN and already an active member of ENA. So that's super, super cool. One of the things that I think really helped his success is that he's got some really fantastic mentors out there in California. So shout out to Matt and Sarah, or a couple of his mentors. You guys are doing an awesome job, and Justin's going to be an awesome nurse. I look forward to seeing great things from him. This week I have a great show for you. My guest today is a longtime ER nurse, former flight nurse, and now a nurse leader. He has got some crazy stories that you're going to really enjoy. So enjoy this week's podcast with my friend Jason.
So my name is Jason Perry, and I'm currently Director of Surgical and Interventional Services at a hospital in New Mexico. My background is I started volunteering in EMS when I was 16 years old, and did that at either volunteer or the very low-paid basic level and then intermediate level. And in 2005, I started working in the emergency rooms, and worked in emergency rooms first as a tech and then as a nurse up until 2 years ago, whenever I took over this position in the OR, which is a big change for me. I've worked in flight and also in ICU, and both in fixed wing and helicopter transport, and worked in level 1 emergency rooms and very, very small rural emergency rooms as well. So kind of the gamut.
What would you say would be the biggest differences between the large level 1 centers that you worked in and some of the small rural centers you worked? What were the biggest differences you noticed? One with the, just the facility, and then two with the people.
Sure. So the very first emergency room that I worked in was a very small rural ER. We had 4 beds. We worked a nurse and a medic, and the medic was at this pretty much practice at their full scope, which was nice. So any intubations or things like that, they took care of. And I learned a tremendous amount there because some doctors, there was a call room that they would sleep in or stay in, but some of the doctors, if they were local, they were dispatched from home. Wow. And so one time, this is something you'd never have happen in a level 1. We had a guy that was having an MI. I was actually working as a tech, and we called the doctor to come in, and he called us back and says, my car won't start. And so I was sent by them to go pick him up, which I was on my motorcycle. And so I show up at his house, and he loads up on the back of my motorcycle, and we, head back to the ER while this guy's having an MI. And so that's not something that you would have happen in a rural or in a big city hospital. And so I think that I learned a lot more because of the lack of resources. In that same rural hospital, we had an MCI. We had 7 patients that were ejected from a vehicle, and they all showed up pretty much at the same time by the volunteer services, so they were on a backboard and had oxygen on. And so I called my parents to come give me a hand. Both of my parents were ER nurses. They did not work for the hospital, but I needed a little bit of help, just kind of getting people kind of situated and triage until the cavalry could come in, and they lived nearby. So my stepdad actually came in and gave us a hand starting IVs and things like that. So
that's funny.
That's where I really learned to be resourceful because you just didn't have the resources. It was just you and a medic.
That's crazy.
A lot like flying.
Yeah, I'm sure.
Yeah.
I'm sure. Yeah. So how long have you been a nurse?
I've been a nurse since 2007. So I guess, what is that, 12, 13 years? Yeah.
Okay. And at what point in your career were you sure that you made the right choice and that nursing was definitely for you?
I still wonder about that sometimes. I don't know if it is the right choice. No, whenever the previous career I had I was in retail. I was in retail management and was fairly successful in it, but just hated every single minute of every single day, and quit. I quit doing that and was kind of just trying to figure out what I wanted to do, and went and worked with my stepdad, who was an ER nurse, but he was also he's a former ER nurse and was a nurse practitioner. Was working with him, and that's when I made the decision to go to nursing school.
Nice.
And I did it for the job security. I have 4 kids of my own, and I have 2 stepkids, so a total of 6 kids. And so I did it for the job security. It's above average income. As you know, we're never going to get rich doing it, but I have good job stability. And even if I get fired, as long as I don't do something super stupid, I'll be able to find a job someplace else.
It's right? Usually the case. It's usually the case.
Right.
Absolutely.
And I'm kind of in charge of my, to a certain degree, in charge of how much I make, because I've always been able to find a PRN job or pick up an extra shift somewhere if I needed to. But I do dream of being a rock star someday, although that window's closing on me, or playing professional football, although my knees are pretty much blown out at 45, so I don't know about that anymore. So
that's funny. You're like, well, until the NFL calls, I guess I'll still be a nurse.
Yeah, I'll continue doing this. Yeah, but I do try to do a good job, or to do my best, and so nursing has allowed me to live the life that I want to live, and I do most of the time feel like I'm making a positive difference.
Yeah. Now, your time in retail management, how did that help prepare you for nursing? Because to me it seems like management's management.
Sure.
But how did the time in retail prepare you for nursing?
I think from the business side of it, being a director, now I run the business side of the areas that I'm over. Similarly, I have budgets that I have to come into, contract negotiations and things like that. I think it prepared me very well for that. I think that whenever I was bedside, it's really about how you connect with your customer in retail or your patient in healthcare. And if you really care about connecting with those folks, of course, the stakes are much higher in healthcare. But if you do right by your customer, by your patient, then you're probably going to be successful in what you do. And I think that that's probably the correlation that I would see.
Absolutely. I think that there's a lot more similar than there is apart. I remember doing an interview with a guy, and he shared his retail experience as something that would prepare him for working in the emergency department. And I was like, wow, angry customers, people who are pissed off, people who have expectations that you can't meet. That's healthcare. It's healthcare. And he was like, yeah, he worked at Walmart, and he's like, that's Walmart. He's like, I'm ready.
Yeah, I was when I left, I was actually a district manager for Walmart, and so I was been a store manager, an assistant, truck unloader, just a little bit of everything. And yeah, it was people wanting more than you're probably able to provide. That's an ER nurse right there.
Absolutely.
Yeah.
Ain't that the
probably
truth?
Having a bad day too, because I've never had a good day at Walmart.
Well, so
yeah.
Tell me about a patient that you took care of that changed the way you practice.
So when I worked in the ICU, I took care of quite a few people who were end of life, and maybe that as being an ER guy, and that's a different thought process because you're really trying everything you can do to stop death or the imminence of death most of the time. But sometimes in the ICU, your thinking changes and the Maslow's hierarchy of needs flips upside down, and you're trying to make a person as comfortable as possible and give them as much dignity as possible as they exit this world. And so there was a patient that was end of life. She was young. She had multiple comorbidities. I believe she was in her late 30s. And she had kids who were all under 18, and so her brother was making decisions for her because she was no longer able to make those decisions for herself. And then it was challenging because we all knew what was going to happen and how to make that patient feel dignified in death, but still being able to convey to the family that everything has been done and we really need to change our thought processes and kind of make her comfortable rather than continuing to be invasive. And so navigating that whole process has really shaped my own thoughts about how I want to die and how I want to take care of future patients who are in that situation. It really taught me the meaning of being an advocate in the most difficult situations, because really there's no good outcome here. So we have to make the best choice of the best choice out of a bunch of really bad choices.
Yeah. Sometimes that's what we're doing, is trying to do the least harm when it's not going to be good.
Sure.
So.
Sure.
Yeah. I think one thing we often do is ER nurses is, we end up being the calm and the ones who are kind of putting things together when things are kind of falling apart for our patients, and
sure.
Having those experiences where when you've dealt with death and something so imminent and tragic, I think then you deal with something that's kind of mundane and you're like, this is easy. We got this. This is not tough at all. So,
Well, I remember we had a code come in that where the fire department was doing compressions on a patient. They show up, the guy's in full arrest, and you get to looking at him, and I recognize that he was chronically ill, and ask the questions while this is going on, and realize that the guy is a hospice patient. Was found down. The hospice caregiver, it was her first day on the job. She shows up. He's down on the floor. She calls 911, and we start this process. So they have the whole big binder full of stuff. And so my immediate go-to was, are we doing the right thing?
yeah.
And we need to make sure that we're doing the right thing. So I look and find that he has a DNR. And so then we have to really shift our thought process in the emergency room, which is really hard to do. But we also need to be respectful of this patient and their wishes, and say this is how they stated that they want to go, and to be an advocate for them. And I related back to my time of that patient in the ICU,
Yeah.
and said, like, dignity is of paramount importance. We have to turn that pyramid upside down and focus on self-actualization rather than just keeping a heart beating.
Yeah, absolutely. Tell me about the first time you made a midair.
Well, I don't recall the first time, but I remember a few times whenever I did, and I'll tell you about the most recent one I did. I was working in the emergency room a couple of years ago, and I would show up to this patient's room, and I kind of use self-deprecating humor to kind of lighten the mood, because I know my patients are having a bad day if they're in the emergency room. So my opening line sometimes was, you drew the short straw and you got me as your nurse. My name is Jason. Sorry you didn't get a good nurse, but I'm here, and we're going to get through this shift, and things like that, just kind of to lighten the mood. So I say, what's your name? And she's like, my name is none of your business, you fat, you know what? And I'm a little sensitive about my weight. I'm a bigger guy. Although I've lost weight this past year, I that's something you don't really want to hear as soon as you walk into a room is that you're, a fatty. And so I was like, oh, it's going to be one of those nights. And for some reason, I allowed her to get under my skin a little bit. And so I just was like, man, this is 12 and a half hours of dealing with this patient. And so she had an order for tramadol, and so I go and pull the tramadol and give it to her, and she tells me, this isn't tramadol, and it's like, it's tramadol, lady. Like, I've been doing this for 12 years. I know what I'm talking about, and this kind of thing is what this internal dialogue that I have. And she's like, well, I know it's not tramadol. And I said, well, maybe it's not the brand you take. Maybe it doesn't look like what you take, but here's your tramadol. So she takes it. She calls me 30 minutes later, and it's like, I don't feel anything, this whole thing. And, of course, the eye rolls ensue and everything, and I'm just like, man, like I said, I'll really let her get under my skin.
Yeah.
So fast forward a couple of weeks, my director calls me into the office and says, hey, do you remember this patient? And I didn't recognize their name. And he's like, well, the order was for tramadol, and you pulled trazodone. Like, what?
Oh no. Oh.
And so I was subject to a random audit on these counts, and sure as hell, I did. And so it was a good wake-up call for me. Like, I typically, I do make it a point to listen to my patients, whether it's starting an IV and they say, this is where they have a good luck with it, that's where I'm going to go, just because why not?
Yeah.
And things along those lines, like, I really listen to my patient, but I let that patient get under my skin, and she was right, damn it. Like, she was right. And I let my own ego get in the way, and I made a midair. And so there I'm sitting there, and I'm like, I should call her and apologize and tell her, like, she was right, And my director's like, no, don't do that, please don't do that. But I was, because of, I let my ego get in the way, and I let my feelings get in the way of providing excellent care. Like I didn't even, like I know that,
like
I know
you didn't
what
even
the
question
tramadol
it.
looks like, lady.
Like you didn't even question it. Like if it was like a normal grandma who's like, hey, this doesn't look, but it's easy to explain because it's easy to
Sure.
say, well, this isn't the brand, this may not be the brand you take. But
Absolutely.
Because a lot of times pills look different. But
Sure. Yeah, I take a blood pressure pill, and every other week something's getting recalled, so they're always giving me something new. I don't know what the hell it's going to look like.
Yeah.
And so it was the same kind of thing in my head, and I was just so easily dismissive of her because I allowed her to be dismissive of me and of my care, and it was a extreme wake-up call, and I use that example in my classes whenever I'm teaching, and to say, hey, it's the first day in EMS when my old EMS instructor says, we don't run in EMS. And it wasn't just about running, it was about slowing down and double-checking. No matter how many years you've been doing it, you gotta get back to the basics, the 5 rights. Or I guess they're up to 7 or 10, or I don't know how many there are, but there's a lot of them.
There's a lot of them.
When I was in nursing school, there were 5. So
it's kind of funny. It's kind of funny how and patients can get in your head because they'll, if they're mean and hateful, they're gonna look for anything to pick on you, whether it's your size, your color, your religion, your sexual orientation, whatever the case may be. They're gonna look for something to just poke that last nerve. And if they
absolutely,
and if they get it, and sometimes they do, it's hard not to let them get in your head.
Sure. Yeah, I when I was flying, I handed it was a double nurse flight. We were going to intubate a patient, which you got 2 nurses intubating in the back of a helicopter. That's a recipe for disaster. So I'm drawing up the RSI meds, and I draw up the entire vial of ketamine, which was 500 milligrams of ketamine, and I hand it to my partner, and because I'm going to secure the airway, and so I'm like, let's go ahead and give the ketamine, and I said it just like that. So she gives the entire 500 milligrams of ketamine.
Oh my!
Which is a very, very deep K-hole to go down, and then I was like, how much ketamine? I was like, where's the rest of that ketamine as we're done? And she's like, oh, I gave it all. And I was like, that was 500. And she's like, oh, I thought you handed me 100. And so just in those, I mean, it can happen all the time. And you're just like, oh my gosh. I mean, thankfully, we already had a secure airway. The blood pressure was a bit on the high side, but that was the only negative outcome. But it can happen really to anybody, and quite easily.
So easily those things can happen. I remember one of the first meders that I did, I gave a med, and I was like, wait, what did you just give me? Because I had 2 syringes there. And the resident handed me the syringe, and I gave the syringe, thinking I was giving one drug, and I gave the other, and I was like, I just gave like double the dose.
Yeah.
And you're like, oh my gosh, holy cow! And the patient was fine. We took care of him. He was good, but it was like, yeah, it's sobering. It like makes you feel like, holy smokes, you're like,
right.
And you wonder, you're like, oh my God, what's going to happen to me? And what's going to happen? And what do we do? And, is the patient going to be okay? And, is the patient going to be okay? And then am I going to be okay?
Sure.
And you think of the patient first, but there's that self-preservation in you that kind of goes, geez, what's going to happen to me?
Right. I got to feed my kids, and I got a sack load of kids.
That makes it tough.
Sure.
That makes it really tough. And it's
yep.
Yeah. Because nobody wants to be forced to look for a job. So
sure, I'm with you.
What's the best advice your parents gave you that you ended up taking into your nursing career?
So my mom graduated from nursing school, I believe, in 1974, which was about a month before I was born. I think is when she graduated from nursing school. So, and she's been an ER, ICU nurse. She works in home health now, so she's got a bit more experience than I do. But whenever I first started down this road, she told me, like, to always remember that patient is somebody's brother, somebody's mother, somebody's grandma. And my family is of paramount importance to my life. And so I've taken that very, very seriously. Like when I saw my grandparents die in an ICU, it had a profound impact on me. And
how old were you then?
When my grandfather died was in 99, so I was in my mid-20s.
So you're an adult.
Yeah. And then when my grandmother died was in 2003, so right before I got into the business full swing. And so I was an adult, and it did have that impact on me. So when I'm taking care of my patients, like, there's been multiple times when I'm taking care of kids and I'm like, have to double check that that's not my kid lying there. Yeah. Because they're the same size or the same age, or they've done something that reminds me of them, or something when I'm taking care of a little grandma, like it reminds me of my own grandmother after her stroke, needing help to the restroom or getting help getting in and out of the bathtub. So I really do take that very personal. It's hard to keep from being able to provide that level of care of that is somebody's grandma, that's somebody's son or daughter or brother, without becoming emotionally attached to the point where it's detrimental to your own mental health. But I think that there is a balance in there that can be had, but maybe that's sometimes difficult. But remembering that that's somebody's family, it was the best advice that I think that my folks gave to me.
How do you keep that? How do you maintain that professional distance? Because sometimes it's hard. Sometimes it's hard to not get wrapped up in their story. Sometimes it's hard not to get caught up in the drama. I mean, you get the drama mama show, and it's hard not to get excited and get like freaked out and get like nervous when there's a lot of stuff kind of going on all around you. How do you separate that?
It's been difficult. When I was working in that rural ER, we had a cold water drowning, a 7-year-old that was actually cold water drowning by a parent.
Holy cow.
And the kid was brought in, and he was the same age as my youngest son at the time. And because of cold water drowning, I don't know if it's still this way, but at that time, they're not dead until they're warm and dead. So we spent about 2.5 hours coding this kid while we're doing warming procedures so that we could pronounce. And so it was, and there were, like I said, it's a rural ER. It's a nurse, a medic, and the doctor. That was the three of us. So we took turns doing compressions 2.5 hours while we're doing warming procedures.
Holy cow.
And he was the same size as my child. My youngest son is kind of all skinned, and this kid was all skinned. And I again and again and again, I checked to make sure it wasn't my son. And that stayed with me for a long time. And then I realized that I had to come up with coping mechanisms that were healthy in order to be able to continue to do this. And then I had to put a finite period of time whenever I was recognize that I needed a break, and to take that break, to first recognize it in myself, and then to take that break. But it is difficult. But it's a thing that I really, really believe in. And even over the last 3 years, I'm even a bigger advocate for. So my stepdad was a ER nurse for many years, and then he was a family nurse practitioner and acute care. He did acute care, and but he did not develop good coping mechanisms. He struggled with alcoholism and prescription medication abuse. He was clean for a lot of years, like 14 years, but he had a relapse. And 3 years ago, he committed suicide.
Holy cow.
And I believe strongly that it was in part due to the shit that he saw in our profession and did not develop good, healthy coping skills to deal with that shit. And so I think that you have to find a positive outlet to deal with it. And to build healthy relationships, I focus on building healthy relationships with people, my wife, who is not in the profession.
No.
She is a designer. She has nothing. When she gets around some of my medical friends, she says she understands about 20% of what we're talking about, and that is by design. I'm glad that she's not in the medical field because it allows a healthy outlet for me.
Yeah. So what do you do? What are your coping mechanisms? Like, what do you do to once you're, get home after a stressful day, you're working a 12-hour flight shift and you get done and your head's just full of ghosts. What do you do to go and clear your head?
Well, now I've discovered I really like to exercise. And so it's in the last year and a half, I've lost almost 80 pounds, and I do yoga. I go for hikes. I go to the USC gym and hit a punching bag for an hour, whatever. But it's some sort of exercise, and that's been my positive outlet. And the thing is that that'll be different for everyone.
Yeah.
Some people might go to a punk rock show and that's what they like to do, or maybe meditate, or maybe hang out on their back porch and look at the sandias. Maybe that's their outlet. But it's really important to find, I think, for people to find that outlet that's healthy.
For sure. It's, you don't realize what an emotional toll that this job can take on you. Like you don't realize it. Like you mentioned your father-in-law, that the emotional toll over all those years. I mean, it takes a toll. I mean, it takes a little piece of you every time. And unless you have something to kind of help piece you back together, it's hard to get back.
Yeah, it is very hard.
You mentioned providers that end up having problems with drugs or alcohol. Have you ever had to deal with that in your professional life?
Well, when I was a charge nurse at a large hospital, we unfortunately had to terminate several nurses for reasonable suspicion. And I think because I dealt with that with my stepdad for as long as I had, I kind of was in tune to it a little bit more, or more aware of it, just because it was something that was going on in my personal life. And so when somebody goes, "Oh, Joe Bob pulled out 40 or 4 milligrams of morphine on my patient. I wonder why they did that." And just like wondering that out loud. And they go, "Yeah, that is kind of weird. I wonder why they did that too." And so it causes you to kind of look into that a little bit. It's unfortunate because you know better than most, I'm sure, that that's a very common thing, especially among emergency room nurses, that diversion piece of it. And but yeah, unfortunately, I have had to deal with that, and it's not fun at all.
Never easy to deal with, and never easy to see somebody who's thrown their career away in that way, or that have had that ends up with those kinds of addictions. It's pretty hard to see.
Yeah, for sure.
Tell me, what is the worst advice a nurse ever gave you?
The worst advice?
Yeah, worst advice someone ever gave you, where you're like, oh my god, and maybe you didn't know it at the time. Maybe afterwards you're
Sure.
like, oh, yeah, it was terrible advice.
Yeah. I did have one of my preceptors one time that I just spent the entire 2 or 3 weeks thinking, I've learned so much from this person by not doing anything like them. Like everything they do, I'm going to do the complete opposite.
Yeah.
But I was working in a PRN gig at an emergency room, and basically he said, you need to be an expert at everything, which is impossible. I can't be an expert at everything. And he fancied himself as an expert at everything, but didn't really realize his limitations. And what I think what I took away from that was a safe nurse and a good nurse is not the nurse who knows everything. It is the nurse who realizes that they don't. And I think that is, that unwitting advice that he gave me that I've carried with me. And so if you don't know how to do something, you got to own that. And you got to say, I don't know, and not just march willy-nilly down the path and go, oh, I got this. I know how to put this person on a CPAP. I know what a delta P of 15 is. And next thing you know, you're giving somebody, inspiratory pressure of 80, blowing out a lung or something. It's not what you do know, but I think it's more realizing what you don't.
Absolutely. It's important to know. I always get a little nervous with the nurses that seem to act like they know it all. You're like going, I've been doing this a long time, and I don't know everything. I mean, there's a lot of stuff I don't know. And you're like, maybe you should talk to somebody. Maybe you should look that up.
Sure.
So,
well, I'll tell you, like the when I was flying, I did some fixed wing transport, and I got called on a balloon pump call, and I'd gone through the training, and I'd ridden along with other people that was in charge of those flights, balloon pumps, and my sphincter was very, very tight for the entire 4 hours I had that patient. And I had my protocols out. I called the medical director at 3:00 in the morning, half a dozen times, just for reassurance. And I'm like, by this time I had 300 flights under my belt. Like I should have been, fairly comfortable with it, but I realized that, it's better to double check. Like it all went off without a hitch, but still it's like, man, I know where that balloon's at. This is scary.
Yeah, it's those super sick patients, man. Those will make you nervous.
For sure.
Sure.
Yeah.
Interesting. So, what advice would you give a brand new emergency nurse?
Realize that you don't have to know everything, and then realize that you never will know everything. I think that, the first 2 years you're out of nursing school, you realize you're running around completely stupid. And then the next 4 years, you think you know everything. You have a bad case of rhinitis. And like, oh, I know. No, you don't know. Just chill because you don't. And so I think that's the advice that I would give is like, you don't have to know everything. And when you think you do know everything, you probably don't. So just embrace learning. The last place I was precepted as the emergency room nurse, like I said, I'd had years of flight under my belt and had worked as a charge nurse in a level 1 trauma center, show up to a 15-bed ER PRN, and my preceptor had been in the ER, I think, maybe a year and a half. And she was a new nurse, but had been in the ER for about a year and a half. So I guess on paper, I probably knew as much as she did, if not more. But I didn't wear that on my sleeve. And I'll tell you that nurse to this day has taught me a lot about being an ER nurse. Like, I learned so much from her, even though she had way less experience than I did. And so I think always know that you have things to learn and to seize those opportunities.
Absolutely. Tell me about a patient that made you laugh. Like, tell me about a patient situation that just kind of brings back a funny memory from the ED.
So most of the funny memories are kind of that I'm a ER nurse and I've got a dark sense of humor, maybe a little bit.
You're gonna tell us a story. You're gonna tell us a story that's gonna make us think you're a terrible person. Is that what you're telling us?
Yeah. So we had this guy come in, and it was an MVA. It was a motorcycle versus a semi, and the fact that he was still living was pretty impressive. But when we get him in the trauma room, we're undressing and getting everything open. And so I'm relegated to the shoes, and this guy had all these big motorcycle type boots, slip-on boots. And I'm tugging on them and things like that, and pull one off and get it off. And the other one was a little bit harder to get off, so I, gave it a good tug and got it off and threw him in the corner of the trauma room and get to setting about doing something else productive if I can find anything to do productive. And so the chief resident, surgical resident, is there and is calling out injuries as he sees them from head to toe. And so he's like, we got this abrasion to the left arm, and they put in a chest tube and road rash on the right hip or things like this. And he's like, we're missing the left foot just above the ankle. And I'm like, and I hear this, and I'm like, what? The left foot? And I turn around and look, and sure as hell, he doesn't have a foot. And I'm like, I took off 2 boots. So I walk over there. And look inside. I'm like, holy hell! I pulled this guy's foot off. It's still it's like wrapped up in his sock, and I'm like, what'd I do? I just didn't know what to do, so I don't know. It was, it took me back to, and actually that was the second time in my career that I accidentally pulled off an appendage.
Okay.
Yeah. So it took me back to the first time I was, 16 years old, 17, doing this ride along with a volunteer service, and we got called out on a guy who had been dead for several days. He had an MVA, rolled down a hill, his truck fell on top of him, and so we're basically just bagging him up. And so I'm there with all these country bumpkin volunteer firefighters, and they're like, boy, get down there and pick up that guy and put him right here in this bag. So I grab a hold of the guy's wrist and give it a good tug, and sure as hell his arm comes off. And I was like, I didn't know what to do. They're all kind of laughing at me. Not kind of, they were he and Han at great. And I didn't know what to do with it. I just put it down back beside him and walked back up and got in the rig and sit down. Just like, I don't know what to do. So that's funny. I guess those are the 2 patients that make me think of, that I kind of laugh. And I think that's dark, but you understand that. And I'm sure a lot of your listeners will understand why it's funny as well.
Absolutely. So the last question I have for you is a question I call 3 things. So it's, what are 3 things an emergency nurse should always remember? And what are 3 things an emergency nurse can just go ahead and forget?
Sure. I think the thing to forget is our care plans. Like, you get out of nursing school.
Yeah, you're not doing those.
Forget them. Although in my master's program, I did have to come up with some nursing diagnosis and care plans as well. So maybe you can't completely forget about it if you're planning on continuing, or at least my master's program required that for an assessment class. So, so I thought I was done with them. Damn it!
Yeah, you're like, seriously?
Yeah, seriously. Like I broke out the nursing. I'm glad I kept my nursing diagnosis books from 13 years ago in the back of my closet. But the other thing to forget, I think, are the bad things that patients maybe have said to you. I think sometimes it's easy to take it personally, or the bad things that the families have said to you, or maybe even fellow nurses have said to you, to just let it roll off, man. Like, just it sometimes it's hard because I think that we're a little bit codependent as ER nurses. Like, we almost need to be needed in some ways, but it's hard not to take those personal. But just forget about it, man. Those patients are having a really bad day if they're there seeing you for whatever reason it is.
Absolutely.
I think the last thing to forget are the mistakes that you've made. Certainly learn from them, but don't just continue to beat yourself up about them. Like, whenever I did the trazodone tramadol switcheroo, I beat myself up for it. It stayed with me for a few days, and I'm like, man, so I learned from that. I'm like, I'm not above this, but I didn't just continue to carry that where I'm like, man, I'm a POS nurse and shouldn't really be doing this if I don't even know the difference between tramadol and trazodone. Yeah. So forget about the mistakes you've made.
Yep.
I think the things to remember goes back to taking care of yourself. Like, they don't teach coping skills in nursing school. I've taken a shitload of classes, Kevin, and there hasn't been one that I've come across, and I'm sure they're out there, but like healthy coping mechanisms for all the bad crap you're going to see.
Yeah, they almost need to, right? Like, almost need to be like have a, hey, let me tell you not to, let this get into your head. Kinda.
Yeah. I think that they do. And I mean, I think the numbers of chemical dependence in our profession points to that. And I think it's easy for a hospital to say, hey, we got these resources, this 1-800 number that you can call if you're having a bad time. But I think there needs to be a more robust system, quite frankly. But until there is, to advocate for yourself first. Remember to take care of yourself, because you can't really be there fully for others if you're not there for yourself first.
True.
Semper I guess.
Yep.
The other thing to remember is that you don't need to know everything. Going back to that, you're safer if you recognize and embrace what you don't know, and then to just walk in with it swinging like you do know everything.
Yeah.
I think the last thing is to advocate for your fellow nurses, and I think that professional organizations like ENA does do that. I'm a member of a few professional organizations as well that advocate for safe patient ratios, continuing education, minimum standards, things along those lines. And I think that we advocate for each other and for our profession as a whole by being a member of those, and making our voice heard. So I think the last thing to remember, I would say, is to take care of your fellow nurses. And that's the way that I do it.
Nice. Anything else you want to mention for the podcast?
Well, like I said, Kevin, I really enjoyed listening to it, and I don't know if I'll ever be a bedside ER nurse again, but it really has shaped my career and I think made me a better person overall doing it. But I think you're doing good work, and I really appreciate it, and I hope you continue.
I appreciate the kind words and the encouragement. It's been a lot of fun. It's been a lot of fun to do, and The feedback has been incredible. People seem to really be connecting with it. So I think they kind of feel the same way I do, that, they want to hear these stories. They want to hear, people's tales. And I knew it was something I was interested in. So I was hoping other people would be as well. So I'm glad to hear that.
You know what I'd be interested in as well? You have a lot of stories as well. Maybe you should take an episode and tell your tale, interview yourself, as it were, or have somebody do that.
Someone else told me that. Someone just told me that yesterday. Just yesterday, somebody said, "Well, when are we going to hear your stories?" And I was like, "Well, maybe at some point. Maybe at some point I'll either answer my own questions or have somebody else. I have somebody else in mind that has offered to play me in the podcast and interview me, which would be, I don't know. It'd be. I think I disclose a little bit each time, and
you do.
It'd be
I
different.
think like I said, I'm a heavy consumer of podcasts, and my favorite podcasts are the ones whose hosts, because I spend an hour a week with these people, right?
Absolutely.
And telling the stories. But the ones that I connect with the most are the ones that I feel like I have like a personal insight into them as well.
Absolutely.
So yeah, I would encourage you. I would encourage that of you. For those are my 2 cents. So there I am.
Yeah.
I'm not doing it myself, but I'm happy to give you advice on how to.
Oh, understand. No, I appreciate that. And that, it's kind of funny. You're the second one in 24 hours. It's told me that, and both were folks that listen to the podcast and are like, okay, when are we going to hear you? And I was like, well, maybe at some point. So
I'd definitely be interested in that.
It'd be, I got some stories, man. I got some stories. I've seen some stuff, but it's maybe not as interesting as everybody else's stories.
Yeah, no, they are, man. Like, there's something about you, like when we worked together, the biggest shit magnet in my entire career.
Oh, yeah.
Evan McFarland. Coming into work, following you, and I'm like, are there really 16 ambulances in the Bay right now? I'm counting 16 fucking ambulances in the Bay right now.
I did have a reputation for being a little bit of a shit magnet.
Is it still that way?
It not as bad. Okay. It's certainly we end up getting weird shit when I'm doing the house soup thing now, and it's certainly we get some weird stuff there. But one of the first days I worked at Texas Children's Hospital, working as a nurse, like my first day, we had a patient that came in and seemed like they were nothing, and we ended up intubating the patient before I left for the day. Mm-hmm. And the preceptor I was working with goes, "Oh my God, this is the busiest day I've had in a really long time." I'm like, I was like, "That's weird. I don't know why that happens. I don't know. It's crazy."
It's called the McFarland syndrome.
It's crazy, huh? One of the last times I was at the university, I went in there and I was sitting there talking to Holly in Holly's little office. You remember where Holly's little office was?
Yeah.
I'm sitting in there, and the charge nurse walks by, and he does a double take, and he looks at me, and he goes, "Oh my God, you're in the building. That explains so much." And I looked at him, I go, "Why? What's going on?" And he goes, "We just got done saying in the trauma room that it was like a McFarland day here, that they were like, oh my God, this feels like it's a McFarland day. What the hell is happening?"
Yep.
So he's like, "You got to come back to the trauma room." So I go back to the trauma room, and they're busting at the seams. There's people in the halls. And I go up to the nurse and I go, "I heard maybe you spoke my name today." And she just goes, "Oh my God, what is happening here?"
Yep.
She goes, "We just got done saying how it feels like you were here again." And I was like, "Oh, look at that." And she's like, "Speak of the devil, and the devil appears." And yep. I just had to laugh. I was like, "That's really funny." And then I was like, "Well, I'm gonna go before I'm blamed for this." And I was like, "What are the odds?" So I did tend to have some pretty busy shifts. It was
yeah. Well, what was always, I'd be like, I'd come in and relieve you, and you'd be like, "Yeah, we actually had empty rooms till about an hour ago." I'm like, bullshit, you had empty rooms like an hour ago.
I'll never
like,
forget.
no, for real, we did.
I'll never forget one time Linda was walking through the trauma room and getting ready to go to the office, and I'm in the trauma room and I'm like, look at this place, Linda, it's completely empty. And she's like, don't say anything, you're gonna jinx it. And I'm like, no, look, it's completely empty, there's not a soul in here. How crazy is that? And she's like, oh, you're gonna jinx it. And she walks away and goes and does her report and goes and does her assignments and goes and does huddle. And I'll be damned if she didn't come back and there are 5 traumas.
Sure, of course.
in
course.
that 20-minute time frame, we got like 5 back-to-back traumas. And I walk out and she walks out and she's like, are you serious? I'm like, I walked to the pre-huddle room and I was like, hey guys, I need your 2 trauma nurses right away, please.
Right away.
And she's like, she's looking at me like, seriously? And then she comes back to the trauma room and it's just blowing up. And I'm like, yeah, sorry about that.
Sorry. That's awesome.
It's like, sorry about that,
awesome.
but have a good shift. I got to go.
Yep.
So, yeah, we had some good times there. We had some good times.
Yeah, for sure. Well, it's been really nice catching up with you, Kevin.
Yeah, man, it's been great. Thanks for taking the time to do this with me. I really appreciate it.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.